Greetings and welcome to today's webinar discussion titled A Win-Win Approach, Elevating Care Quality While Maximizing Reimbursement, hosted by Brandy Health and sponsored by Cardinal Health. Throughout today's webinar, please feel free to submit your questions through the Q&A option on your Zoom screen. At the end of the program, the speakers will address the questions during the Q&A session. It is now my pleasure to introduce Tanya Park. Tanya has over 20 years of experience in building healthcare IT products in the US and internationally. As a Director of Innovation Technologies at Cardinal Health, she is focused on Navista TS, a suite of technology solutions for value-based, patient-centric care in oncology. I'll now hand it over to Tanya to start the session.
Thank you and welcome to our webinar today. I'm going to introduce our panelists. You'll go to the next slide. Brandy Manning joins us today. She's the Director of Quality and Value-Based Care at Alabama Oncology, and she leads quality improvement initiatives and care management for the practice. She's an oncology certified nurse with 19 years of oncology experience. She's dedicated to improving cancer care for patients in North Alabama and believes strongly that the help of integrated technology and data, we can provide quality, value, and a care delivery process that focuses on better health outcomes for patients. Our next guest, Bo Gamble, probably needs no introduction, but he's been in healthcare for 45 years, the last 25 in oncology, and his latest role has been assisting COA, the Community Oncology Alliance, with promoting quality and value in cancer care. Next slide. For today's webinar, we'll focus first on an update on the ASCO certification for delivering quality care, and then we'll move into talking about how you get reimbursed for providing that quality care to patients. We'll talk a little bit about technology, and then we'll open it up for a panel discussion, and we welcome your Q&A at the end. With that, I'll hand it off to you, Bo, for an update on the certification.
Thank you, guys, and thank you for hosting this webinar. It's a great topic to discuss, and everybody's interested. Next slide. If you look back over the last probably 8, 9, 10 years, you can see where there's now a shift to instead of utilization of healthcare only, where everybody goes to the same doctor and they get paid the same way for doing things, even if they do it differently. There is now a thirst and a yearning to provide good quality cancer care. If you look over the Medicare rules the last 8, 9 years, they've even implemented new service codes to say, oh, we're not going to just do levels 1 through 5. We're going to pay for doing the right thing. Well, and our time today is going to be spent about doing the right thing. About 5 years ago, we worked with ASCO to pull the oncology medical home off the shelf and says, let's revisit it and let's do it better. The first attempt was with the Commission on Cancer, didn't really go very far. But to look at all the changes that was happening in cancer care and to, let's say, everybody wants to know good quality cancer care. Patients struggle with defining it. Employers are always asking for it, not sure what to ask for. Payers want to pay for it. So we now have this model called ASCO Certified, which is a marriage between ASCO and COA to promote these 7 domains, which includes 17 standards within 6 of those, and then the full chemotherapy safety program. It is an A to Z, blueprint or map to doing the quality cancer care for the entire journey. And it does a few things. One is it says, here it is. It doesn't tell you how to do it, but it does say, here's what's expected, and here's how you prove it. And that proof is either in process measures or in quality measures, numerator and denominator. Does everything that says, okay, here's the proof. Now, what's good about the program is it not only is a one-time, we'll look at it, whatever. When you've accomplished all these things, you're quote certified, which is awesome. You'll get a plaque for your office, and we'll have a celebration, and we'll all celebrate. Well, there's also ongoing discussions and proof saying, are you continuing to prove it? What I like about this webinar is the transformation, the care coordination codes that have come out in the last 8, 9 years, transitional, advanced care, principal care, etc. they all fit into this program. And if you look at the details, this program promotes 26 of the different coordination codes saying, okay, provide the right service. And as you guys are probably, if you're here, you're probably like, how do we do some of this? We're going to talk through some of this today, and Mandy's going to do a great job showing you how to do that. But it all fits into providing and proving high quality cancer care for everybody to see. The patient, the family, the care team, the insurer, whether it be the employer or the insurance company, everybody can see now the quality cancer care you're doing. We're moving in that direction, and it's good to see, and it's good to be part of this discussion today. Hope we have some good discussion questions at the end, and hopefully get a lot of good information out of it. Next slide.
All right, thank you for that update, Bo. I think the framework that's been developed with ASCO and COA around what's the right thing to do from a quality perspective. Now we're going to shift gears and talk a little bit about how to make sure you're being reimbursed for that quality care so we can continue to provide that high quality care in our communities for patients. So with that, next slide. So obviously, over the last 10 plus years, we've seen an evolution in value-based care models. Early days were payer pilots. The Come Home project that Dr. McEnany started was significant in that it showed that there could be savings in oncology that trends towards value. So with that, CMS introduced the OCM model. Notably, OCM did not show savings. However, for high-risk cancer episodes, there were significant savings in those, which led us to EOM, which really only focuses on 7 cancer types. We saw fewer practices join EOM, and the practices that join tend to be larger or aggregated under a single tax ID. EOM is challenging because you have a split patient population, you have 7 cancers. And so what do you do with those other patients that you're not able to build a MIOS for those services? We're going to talk about that. And if you aren't doing EOM and you're a practice that's trying to figure out what's next from a reimbursement landscape, these care coordination codes can help you recover as much as a MIOS payment would in a reimbursement for your practice. With that, Brandy, I'll leave it to you to talk to us about continuous care management programs and kind of situational care management options and your experience at Alabama Oncology.
Yes, thank you, Tanya. We're very excited to be here today to talk about the care coordination for Alabama Oncology. We are one of the largest private community oncology practices in the state, with 22 physicians and 6 APPs, and we operate 9 clinical sites of service. And we, as of many other practices, were participating in the oncology care model really to gain more insight into how our practice would perform should we ever encounter a mandatory model. And we were pleased with our performance and what we learned, especially how it transformed our culture into one that prioritizes value and data-driven quality improvement efforts. But when OCM ended, like you said, we elected not to move forward with the EOM, and a lot of factors went into that decision. But ultimately, we chose to invest and develop our care coordination services offerings, as with a lot of practices. We have an opportunity to provide a great service to all of our cancer patients, and though we're still in the early stages, we're very proud of that cancer care that we're providing, and I'm excited to share that experience with you today. So on the screen, just to refresh on some of the care coordination opportunities for reimbursement, and bear with me because we're going to jump into the land of acronyms here. The first 2 are chronic care management, or CCM, and principal care management, or PCM. And as you said, Tanya, these care management services have recurring or continuous billing opportunities when you meet the required time and documentation commitment each month, which is 20 minutes for CCM and 30 minutes for PCM. And we looked at all of the components required for each service offering, and I say offering because you must fully inform and offer this service to the patient, and they must consent to receive it. But both PCM and CCM are very similar, and our initial plan for 2023 included both. However, during implementation, we shifted our focus to primarily focusing on PCM. And we get asked this question quite frequently, is that if reimbursement is about the same, then why would we focus on PCM, which is a 30-minute requirement, versus the CCM, which has only a 20-minute requirement? And as we began to build out our documentation and our workflows, CCM requires 2 or more chronic conditions. And we felt that building out complex care plans that are addressing the long-term needs for multiple chronic conditions like diabetes was maybe better suited for a primary care physician or maybe cancer centers that have an internal medicine multi-specialty. So then we chose to develop the PCM, which only requires the 1 condition, and it allows us to focus on cancer care. Also, billing the PCM service as a specialist in oncology reduced the risk for other providers that were maybe billing the same services, and it allowed us to keep the focus on what we know and do best. Next slide. 2 more care coordination services that provide excellent opportunities are the transitional care management, or TCM, and advanced care planning. Now, both TCM and advanced care planning are event-based or situational, and would only be billed for encounters triggered by a hospital discharge or advanced care planning discussion. TCM is similar to CCM and PCM in that it cannot be billed in the same month as other programs, but the advanced care planning can. Next slide. A few things to point out that we learned during our implementation is, I think first and foremost, is take an incremental approach to implementation. We could set our own pace for implementation and grow from that. We can take our time to develop and implement a solid quality process. And it was important for us out of the gate to provide the PCM service offering to our highest risk patients. We learned early from our OCM participation that a small high-risk patient population accounted for the greatest healthcare costs. By keeping a larger footprint on the small number of patients who would benefit most from the care management, we can drive down healthcare costs in a meaningful way. It was important to work with and build on what we already had. We need this process to fit. We have 28 providers at 9 clinical sites, so operations and resources can differ at each site, but the most important thing that we learned was just to get started. And keeping the value, or the focus on value, we watched the oncology reimbursement landscape evolve with MIPS cost category, or MVPs that are upcoming, and EOM, and of course all of the acronyms that are on the horizon. Our goal, honestly, is to just keep moving forward. And if you've ever heard me speak, our executive director, Chris Barnes, taught me early on that we follow a crawl, walk, run philosophy. But as long as we keep quality and patient outcomes as the core of our decision making, then the value will follow. Another key component would be to leverage technology. Technology allows us to keep the focus where it should be, on the patients, and tech solutions and AIs have already perfected the art of data mining and analytics. I will say, though, that it's important to keep and partner with analytics vendors who understand the oncology landscape. Continuous evaluation and improvement obviously is going to be key with any new program, and understanding the return on our investment. That was a bit of a challenge when we first got started. Of course, advancing cancer care with improved health outcomes and access to care is going to be first and foremost the biggest return on the investment for us. But we've reduced or avoided healthcare costs. We've been able to stabilize acute issues where patients would have been sent to the emergency department or hospitalizations. We've improved, we think, practice performance. Even though we're not participating in EOM, by focusing on reduced healthcare costs, we can improve our performance in the MIPS cost category, which is 30% of our MIPS score. Our human resources, we have our care managers relieving some of the burden on the physician teams, especially in regard to our oral chemo patients, because they're completing oral chemo adherence and monitoring while they're having these phone conversations with our patients. The patient experience, of course, positive patient feedback, and I'll end it with this last one, but the patient engagement is reimbursable.
All right, next slide. Thank you, Brandy. That was a great insight in terms of how these programs can help a practice in both reimbursement and maintaining that high quality care with their patients. I'm going to talk a little bit about the technology landscape and how you may use technology to help you scale and not add extra burden to your practices when taking on these programs. Next slide. All right, so there are a lot of solutions in this area. There's also a poll question that just come up, so feel free to answer that, and that'll close out, and you can continue to see the slides as we go through it. The first I'll talk about is just needing to understand your reimbursement and leverage reimbursement analytics for these programs, as well as tools that give you access to seeing all the things that are happening to a patient in terms of cost across their whole health journey. So number one, you can use it to leverage which patients qualify for care management programs, and make sure you're not including patients where there may be a primary care doctor or specialist who's already billing for, say, a CCM in your area. So that's a good use of seeing all of a patient's claim history to figure out whether you're the right provider to bill for these services. The other way to use these is in the continuous care management programs. It's important that you are billing every month. So you can bill these codes monthly, and it's often that you're providing care and the claim just doesn't get filed. So reimbursement analytics can help you make sure that if I billed, say, a PCM last month, I'm still billing it this month and getting reimbursed for my practice across the patients that are enrolled in these programs. The next one, Brandy talked a little bit about this, making sure how do you start with so many patients, right? A good way to do this may be to leverage population health analytics and risk stratify your patients. That lets you make sure you are offering these services to the patients that really need them the most, and you're reaching out to those high-risk patients to help that intervene before issues arise. The last piece I'll talk about in terms of a technology that can really help your practice scale is patient-reported outcomes and care navigation or care coordination software that helps you do documentation. So ePros are a great way, whether done via an app or done via text messaging, to engage your entire patient population. So a human doesn't have to sit and call every patient. You're actually using technology to scale. And then you're using technology to help you in responding to patients where they need help versus patients who are doing fine and don't need any additional assistance. You can also leverage technology through responding and symptom pathways. Those are good uses, as well as making sure you have that audit trail of documentation or time tracking that these services require to then go ahead and bill for those services. So with that, I think we are probably ready to start our panel discussion. And during this time, feel free to use the Q&A button to ask questions. We're happy to take any audience questions for the panel during any of our discussion time. So Brandy, I'll start with you. Love how your practice is using that kind of crawl, walk, run, and you're just getting started. Is kind of the burden to get started is big here, right? So how did you start with identifying patients for these care management programs, and how did you start small to just get started?
That's a great question. We already had risk stratification processes in place, and we had the support of some of the tools and platforms for that. But we were able to leverage our EMR report capabilities, as well as the Navista platforms, to help us identify our patients. And it was important for us to be able to have the list of patients as we were screening them and processing them, and we can track them on a dashboard of patients. So I think that would be the best way. And that's probably one of the most important tools when you're getting started, is who are my eligible patients, and have I already offered the services to them? And of course, we try to track a lot of that in our EMR system as well.
And what would you say just the patient response has been with these programs?
It's been a really positive patient feedback. The comprehensive service is honestly what every patient expects to receive when they see an oncologist for cancer care. The dedicated care managers are having a meaningful conversation with the patient. They're providing them and connecting them with valuable resources. patients want, need, and they honestly deserve that next level care that they're receiving. And that's what they recognize as a quality service offering. Which is why I think they're so willing to consent and accept the cost sharing that's involved with PCM and CCM. They know that they can opt out at any time, but they continue the service. And I think mostly that's because cancer care is so complex that they appreciate the experienced and knowledgeable care managers, because they're advocating, supporting, and guiding them through a complicated healthcare system. And they're transforming that patient's experience and cancer care journey.
Excellent. I think that's so wonderful, right? That, we almost worry about implementing these services with a patient pay piece, but the response that your practice has seen has been overwhelmingly supportive and excited about receiving that extra service. Bo, how would you say, from a patient journey perspective, that ASCO certification obviously plays a lot into it. What does that process look like for practices from certification, and how do they do it, and how do they get more information about it?
Great question. Brandy, great job too. I love the emphasis on the patient. I would like to come back to that notion of like the pay for, because I think we can fix some of that if we're creative. But with regards to the standards themselves, they're out there. It's public information. It's on, I think, COA's website. It's on ASCO's website. If you can't find it, let me know. We'll send it to you. It's there for you. Now, you'll look at the domains and you'll say, oh, okay, yeah, we do that. But are you really? When we had the 12 pilots that went through the program, they said, yes, we're doing it. Oh, yes, we're doing advanced care planning. Okay, show me. The joke was, we're from Missouri, show me. And they, we did one last week. I'm like, no, you got to do it for everybody that's metastatic. So to make Brandy's point, it also promotes accountability, because these patients are what it's about. And if you can't prove that you're doing it, then are you really doing it? So it promotes doing these things on a consistent basis and the measurement of those things. So the standards are there. Go at it. When you think you're ready, ASCO does a certification, and we're promoting the standards themselves. ASCO can come behind and says, okay, let's validate it. When you're doing it and you're doing it well, if you're ready for a site visit, actually, there's an application because there's some prerequisites. Okay. For example, pathways is now one of the prerequisites. It used to be a standard, but because it's so difficult to implement pathways, it says you need to get that done first. So when it's done, then we'll come in and look at it, and we'll have some discussion, spend all day. Well, we're working here, we're struggling here. We can talk about some solutions for some struggles and could point to some of your tools. When you're ready, you say, here's what we found. You work on it, you complete it to the level that's needed, then you're quote certified. Once you're certified, there's ongoing reporting, both in process measures as well as some quality measures, says you're continuing to do it. There's also a network of people that have done this, so they can talk to each other and benefit from each other. So the standards themselves, it's for everybody to see and do. Do it, use it, do great things, prove these good things. As far as Randy's talking about the patients, and we're seeing even on the care team, when they got it, it's like, oh, we get it. And that whole quality improvement mentality, it goes throughout the team. It says, oh, yes, we're here, we can do better. So I really like what Brandy's doing to make that happen. Because, we're in an era now where people says, hey, if you're good as say you are, then show me. Show me with your work, show me with your care, and show me with the results.
Thanks, Bo. I'm from Missouri as well, so show me resonates.
I love that.
Definitely a mantra of people from the state. So for both of you, I'll ask you, Bo, just in terms of payer landscape and how you see the ASCO certification fitting in with payers. What has been the reception there, and what are the opportunities for that, leveraging that with your commercial payers if you're a practice?
Great question. And one of the benefits of this is to help people prepare for reform models. We are not making progress as fast as we want to. I think part of it's because people are like, I'm trying to get their minds around as well. currently every OM certified practice, it has a free entry into Anthem's Integrity Connect program, free entry, and the standards are aligning. We are also in discussions with Cigna and also with Aetna and a little bit with United. Now, what's interesting, what's happening, if you look probably the last 5 years, all these reform models came out, yet every reform model, you think about it, there's three components. There is the care, there's the payment methodology, and then there's the measures, which is the glue. In every situation, the care requirements were different, everyone. So there was some alignment, but there were some differences. And we're saying, why? How come we're allowing payers to define quality cancer care? So part of our promotion says, use this care platform. And if you see something needs to be added, listen, use this care platform as your care base. You guys work on adjudication and payment. That's what you're good at. Use this as your base. Let's everybody agree. And we're making progress. Now, one payer in particular, we're very excited to see it because their emphasis was totally on reducing cost. But you can reduce cost by withholding care. So this forces you to have good care. So that's our message, not only to the payers, but also to employer health groups and employers. Here it is. I want to touch on something that even Brandy mentioned earlier. As we did our site visits, one thing that my favorite is advanced care planning of all of them, because I've seen what happens when you do that well for the patient and family. And some of the practices, they say, okay, yeah, we've done it, but we're not doing as much as we want to. And like, why not? And the reason was they didn't want to pay for another office visit. So these care coordinations actually open the door for benefit changes. If it's that important, remove the copay, remove the cost sharing to make that happen. It's a win-win. Everybody wins. That way, everybody has, and that way it can happen better. So the care coordination codes actually can lead to some benefit changes to promote quality cancer care. Reward these people are doing great things. Reward quality cancer care programs. That's what it's about. It's not just about, stockholders and payment, whatever. Quality will lead value. If you can provide quality, value will follow behind it with proof.
Makes complete sense. Brandy, what has your experience been with payers in terms of reimbursement for these coordination codes, both Medicare, Medicare Advantage, other commercial payers?
It's been a really positive experience. I think more and more people are accepting of these codes. And so we've started off with our Medicare primary, and that was because most of our focus during OCM was somewhat on the Medicare plans and platforms. But we are seeing more and more private payers that are picking up as well. So.
Makes sense. Yeah, that's what we're seeing across the board too with our practices at Cardinal. Opportunities both in the Medicare landscape as well as commercial payers who are embracing care coordination codes as a way to better care. For both of you, Brandy, what was some of your challenges in rolling this out? You guys were OCM practice. Was it an easy transition, or did you find it challenging to switch over and try to bill for, care management versus a MIOS every month?
I think as a larger practice with multiple sites, varying patient demographics, multiple hospital systems, resources, variability was probably one of our largest challenges. Developing workflows and processes, communication across the organization, and training has to be key when you're trying to ensure that everyone understands what the care managers are doing, and that we're not duplicating processes and services. Another one, probably one of the biggest challenges was with implementation. We're trying to validate our plan, and Bo spoke to this, and it's just important. Our plans and processes, when you're starting, we chose to focus on our high-risk patients because based on our experience from OCM, we felt like that was the best approach. But it adds a layer of complexity because of you're implementing a risk stratification process and you're having to have a patient selection rather than just a simple approach across the practice. Ultimately, we were able to start with fewer resources that way. We were able to build on that. But we can see firsthand the progress that we've made and the value in our approach. But the challenge was really how to make that valuable service available to everyone. Of course, one of the most common answers is more resources. We always want to throw resources at it, but to add resources, we need reimbursement, which goes back to the payer side of it. We need to recognize the importance of the services and programs like these. And so we started evaluating, of course, I mentioned our Medicare reimbursement and all of the payers who began to support some of these services. And of course, for any service program, that success is only as good as the impact that it's having to advance cancer care. So we keep moving forward, but thank you for that question.
Absolutely. And to you, Bo, like for that certification, there were a number of practices in the pilot. What could you kind of summarize some of the challenges they faced as they were going through the certification process?
Great question. And those challenges varied, which was interesting. They varied by site of care. And you would think in some states, like, for example, I'll pick a few pathways. If you weren't doing pathways, that was a big issue. And sometimes in the bigger organizations, there was a lot of resistance to pathways. Like, what do you mean telling me how to take care of my patients? But we're like, no, here's proof that you did it well. Here's the deal. In other sites of care, believe it or not, there's a standard for financial assistance. Your community practices, they've been doing this for years. This is part of their service. They do it well. If you are not a community, then you struggle with that because you've never had to do it. Those are two specific standards. The other thing that I think that was general to everybody, and that was, this was not a project. This was a mindset. This was a commitment. And getting people to commit to the program itself and what it meant. I think it's Dr. John Cox, who's on ASCO, one of our physician leaders. He said the whole program is about quality improvement. When that happened, it became much easier. Let me give you some examples. There are three standards, I think, particularly. One is having to do with pathway compliance. You have to be compliant to pathways and value pathways to boot, but then you have to share compliance with your physicians by physician. Like, game on, good gracious, because some don't like to hear that information. The other thing in which I'll be a fan of, and that is sharing patient satisfaction scores by physician with physicians. This is direct feedback from your patients, how well you're doing. So there's emphasis on communication throughout the program to say, guys, we want to do well. Here's what people are saying about how well we're doing it. And that's driving the quality improvement. If you know your peers doing better than you, then you're like, hey, how did you do that? So getting that mindset, that commitment that says, we're all in this together. Here's how we need to make it happen. And when it starts happening, well, I can tell you, two of the smaller practices on the pilots, we were worried about them. It's like, we're like, hey, they're limited resources, as you know, limited resource, and it's going to take a little bit of effort. It's not a whole lot. We don't put, there's not much required, but you got to be very thoughtful and strategic. We were very worried about them early on, but they became shining stars at the end because they got the commitment as a group. Here's what we're going to do. And they came out like really good. I will share that one of them, small practice, at one time they were being asked to become part of a PSA for a local hospital, which means you're gobbled up. Like, now they are still independent, and their employees go to the community center as a tier 1 referral site. So from being the enemy, now you're a preferred site for care because of what they've accomplished. So that's another piece of the value. You're doing good things. Hey, let's get the word out there. Let's show how things are happening. But the stories were all over the map. Some of them were humorous. Some of them were very sobering. But it was like everybody's starting to understand it, which is good. And now they're becoming very.
I was going to ask you, you kind of talked about small practices, larger practices. Is there a right size practice to get started with this certification?
Not really. It applies to everybody. We want the same rules apply. May the best man win. Everything applies. Now, sometimes it's harder because smaller practices are more nimble than larger practices. Some people have to have a committee working on things. But everything applies to everybody because we want employers, we want the payers to see, here's the things to look for. Are these things happening? That's quality cancer care. It's open to everybody.
Makes complete sense and kind of the right thing to do. I'm glad to hear that, you know, across the board, a practice of kind of any size can consider this standard for them to look to provide high quality patient care. Brandy, we talked earlier a little bit about challenges and administrative burden. You know, has doing PCM added burden to your practice or shifted it somehow?
I think in a lot of ways it shifted it. So many of the technology platforms are geared toward physician dashboards. It was important for us not to add another clinical function to them or their teams because the burden on the physicians has already been pushed to the brink. Not to mention care coordination should make the physician workflow easier, not to add to an already strained workload. So I think for us, it was important to use the integrated tools and platforms because we have our report forms tracking everything built into EMR readily available to the care teams. And advanced analytics just kind of provided our care managers with so much patient detail that the CCM and PCM eligible patients were being monitored and screened. But ultimately, the dedicated care managers, as I mentioned earlier, were able to take some of that workload off, especially like I mentioned, our oral chemo compliance is being adhered to and monitored and tracked by our PCM care managers, and that reduced a lot of the workload from our physician teams.
Makes sense. Bo, do you hear any complaints from those practices going through this? Oh, we have so much more work to do, more burden on us to implement the standard?
No, we didn't. However, we've had many people say afterwards is, you know, that was kind of their thinking, oh no, here comes another program. Afterwards, they says, we're so glad we did this because it meant a lot to our team and we had better care. So if you look at it as like, it's my Tuesday's project, then you're in trouble. If you look at it as it's a way to help transform it, and it kind of gives you a path. It also gives you an excuse because some of the standards are like, hey, we're not doing this, but we should. You can blame us. You can't you can't oh, well, you know, sometimes we blame each other. You can blame us because it's good quality cancer care. So, so far, everybody feels like, as best I can tell, a lot of value. We won't pay her for recognition. I'll also share that Steve Grubbs, who's one of our other physician leaders, has had numerous conversations with CMMI that says, hey guys, instead of them creating their own care standards, why don't they use ours instead? Of course, they nodded and wrote it down, but it didn't happen. But you can see there is a lot of alignment. They do guidelines, we do pathways. We think pathways are more important because there's a value component, but there are some similarities.
Makes complete sense. And glad that it's more of a mindset, right? That you need to embrace the transformation as you go through it versus seeing it as extra work is kind of what I'm getting from you.
Exactly.
Excellent. If a practice has other certifications, Brandy, what's your practice is COPE certified, is that right?
COPE certified. So
yeah. So what about for those practices that already have done a certification, why do another one, or what does that look like as you go through this? Is there a way to convert? How are you handling that?
I'm so glad you asked. And Randy, we got a deal for you. If you're COPE certified, you've got a head start, which is good. You're well down the path because that's one of the hardest. We admit that. But also any monies you pay towards COPE certification can go towards your ASCO certification. It is also very affordable. So yes, there is that transition from COPE to ASCO certified. As to other certification programs, you know, we early on we talked to JACO, we work with Commission on Cancer. I'm a fan of this one for a number of reasons. One is it's we help you all along, and it's not simply about policies. In fact, when we met with them, show us how you're doing it. They want us to give us a policy. I'm like, thank you for having such an eloquent policy. Really good job. However, did you do it? That's the proof. So ours emphasizes doing it and how that doing it shows up with processes. And then there's ongoing validation. You're in it, you're submitting as long as it's possible. And there's the like benchmarking measures that we could help. Everybody's doing the same way. We want to raise the bar while looking at similar measures. So that's different. Certainly, you'll get a certificate. You can put it in the lobby wall. We love that. We'll take pictures of it, put them on Facebook or Instagram, whatever. However, it is an ongoing process because you've gotten the full commitment of ASCO. And you think about it, the COPE certification team, Rhonda Momans, the lead surveyor. I worked with Rhonda, been working with Rhonda now for like 5 or 6 years now. Really enjoy working with her. It's the same team that will do the inspections for the OMH. So that base, those certified team members, they're just transitioned to this. And that's why COPE is folded into the program. In fact, now that you ask, that's how the conversation started. I remember it well. ASCO came to us at a payer summit, as a matter of fact, and says, you know, COPE's been around. Initially, payers were paying for it because they think, hey, there's a certification program, we can recognize it. Over time, they stopped because they didn't see a difference in value between a COPE and non-COPE practice. So then the question, can we work together to add value to cancer care teams as well as payers doing this together? That created the marriage and the relationship and how COPE got folded into the program.
Excellent. I'm glad there's a path forward. It's like you can leverage existing to get to the new certification. We have got an audience question. Brandy, this one's for you. So do you have a dedicated care coordinator, or is it kind of wrapped up into your existing nursing programs? Can you talk about how you're kind of organized as a team?
Yes, we kind of integrated it. We have nurse navigator, but we also have the dedicated care manager. And so in the patients, as part of the program, is that they're getting a call from this dedicated care manager, which makes it so valuable because the patients get to know and they are having these conversations with the same person, and they start to communicate and they develop a relationship and a trust and a rapport. But it's dedicated care manager.
And that trust goes a long way in the care process. They got to have that trust, got to build that trust.
Can you add on a little bit about when you're doing that enrollment or getting the patient consent to be part of these programs? Who does that at your practice? Is it the same person, or are you approaching that piece of it differently?
No, the physicians bring it up and have approached the conversation with the patient. Initially, we were just going to have lists and we were going to explore how to discuss these things with the patients. And we felt like whenever they're seeing the physician, he's in it or they're in a better opportunity and a safe space while they're in that visit with the patient to have the conversation. And then once the patient says, yes, I'd be interested in hearing more about that, or I want to do that, after that, then our physician lets us know, and then our dedicated care manager calls. He confirms the consent, goes through all of the rules and the requirements of what that looks like, about the cost sharing, everything that's going to go into the program, what the expectations are from the patient and him. Then they're having a detailed, of course, every patient gets a thorough chart review. We're reviewing all of their treatment plans, their medications, their regimens. And so we have made it a point to make sure that the dedicated care managers are nurses, because they can help the physician teams if they need prescription refills. Are they having symptom management? So we implemented a triage process while they're having these conversations. And that was especially true for our oral patients, maybe who aren't coming in to see the physician every week or every 3 weeks. So that all of that has been built into our EMR documentation. So once that's done and he's documented everything, and then we send the patient, hopefully through our CareSpace portal, but if they refuse that, he sends that to them in the mail. And so they have a complete care plan, what their goals and expectations are, and what we're doing to work toward those goals. But then they also have someone who's checking in on them.
Excellent. I got one more for you, Brandy, from our audience. So you talked about how Alabama, you guys focused on high-risk patients first. Can you talk to us about what was included in that high-risk population? How did you define it and target those patients?
That was a good question. First and foremost, we started with just like clinical aspects and their lab reviews, the specific diagnoses or pancreatic cancers or different high-risk cancers, high-risk chemotherapies, what type of chemotherapy were they on, to really just kind of give them a risk stratification code. And we were doing that through our OCM. And then we partnered with some partnerships, platforms, and tools, and JVon was one. So that allowed us to work more into the social determinants of health and financial aspects and other risks. Maybe even it goes so far as to present us with information about their education background, their demographics and landscape where they live, their home situations. So just that I guess, additional support provided our care managers before they even get on the phone call with the patient. They have another level of risk factors that go into how they can approach that patient with a conversation. So are they asking questions about their transportation? Are they able to get to the clinic? Do they have groceries? I mean, when we ask them to tell us about their last meal or what a typical day of food looks like for them, what was your meals for yesterday? What was your intake? Those simple conversations are all strategically asked based on some of the information that we have that can help us provide better care for those patients, and what kind of resources do we need to be offering them to help them.
Tanya, if it's okay, I'd like to add on.
Yeah, go for it.
One of the things we saw in the pilot, because there's an emphasis on SDOH and health-related social needs in the pilot as well. And I'm like, I was like, this blew me away. One of the teams, as you know, SDOH, the measures, the criteria is all over the map. And sometimes it's hard to do, like housing. How can you get someone housing? However, a big issue was for this practice was food insecurity. So as they talked to the patient, they saw that they had some issues there and they needed better nutrition. So they had created an arrangement with a chain of grocery stores in their community, a chain, not just one, but a chain. When food insecurity was identified, they gave a grocery list pretty much to the grocery store. This patient needs these things to help them in their care and their life. The police department delivered it. Like, boom.
Wow.
What a phenomenal idea that is. And you're being a great steward. You're just being a servant to your community. And like, man, this is all, everybody needs to do this. This is really good. So big fan of like helping patients where they're at.
That's a wonderful stories from the both of you, the impact on patients by, kind of uncovering what you don't know through the use of SDOH. It's really fantastic stories about being able to reach another layer of what patients are going through. It's fantastic. Excellent. Any other audience questions? Feel free to put those in the chat. For both of you, either leveraging care coordination codes or certification, how does it help a practice prepare for whatever's coming next in the value-based landscape, whether that's an iteration on EOM or something new?
And you want to start first?
I think just kind of keep moving forward, I think is our mindset, and just always be progressing towards value for the patient. And whenever we're looking at different resources and platforms, and if it doesn't impact what the patient is doing, it doesn't need to be a check the box kind of thing. And one thing that we threw out years ago was standard of care. We don't like to even use that term in our organization. That was something, early in my nursing career, 19 years ago, I would hear that's not standard of care. So as long as I've been at Alabama Oncology, that's just not even a term that we like to use. So just looking for, I guess, programs that can identify your eligible patients and just get started. Even if it's like us, we're on a smaller scale, like we're just trying to make an impact for those that can impact and have in a meaningful way. And I know I used that term too many times today, but it needs to be a meaningful interaction in an encounter.
Brandy, I agree. If you looked at some of the transition, I think we're going to continue to get wiser, smarter. I think healthcare is going to continue to evolve. And I think the demands are going to continue to be defined. Here's what I'm expecting in healthcare. And it's going to be quantified versus qualified, like it's been in the past. If you look at even the care coordination codes, they've been added and modified. We're going to see more of them. more and more. Now they're complicated, and hats off to you guys for figuring out some of the complications on PCM and CCM. Seems like those are some of the hardest. Hats off to making it happen. It's going to continue to happen. So if you're not in that transformation mindset yet, you need to be, because everybody's going to want to know the care they're being provided and know it's good quality cancer care. Healthcare, to me, is very exciting in this era, because there's like an awakening that we're finally defining healthcare as it should be. It's hard because, you know, how do you define it? You can go to Kelley Blue Book and look at a car, and you can see compare. How do you compare healthcare between sites, and how do you know what's good versus different or better? So it's going to continue to grow. We're going to continue to learn things and have to adjust to things, but I think it's all good.
Makes complete sense. One more question from our audience. I am in a border town, an underprivileged community. They're having a hard time consenting patients because that can be seen as extra financial burden. Any tips, Brandy? I don't know how extensive your patient population has been, but anything that you found that has helped in that area?
Honestly, just that conversation, that frank conversation up front with the patients. And one of the things we tell them whenever there is cost sharing is that we explain what that looks like. If they have a Medicare program and it only pays 80%, that they may be expected to pay a specific amount out of pocket. But we go ahead and tell them, so it may be $7 to $15 a month. And I have been very surprised and excited by how many patients actually want to move forward with that, just knowing that, because once they hear what the service is, especially, again, I can't tell you how many times we've heard it, cancer care is just so complex. They're confused. Their navigation needs to be supported. There's just so many things in the realm of cancer, and just the overwhelming nature of a cancer diagnosis. They've almost always been able to and willing to accept that copay. But of course, if you have a financial team, we have patient financial planner, financial counselors that have conversations with our patients. So we can immediately refer them to the patient financial counselor. So if there's access or grants or any type of foundation assistance out there, then of course, those are always great opportunities. So if you don't have patient financial counselors, those are always a great asset to our practice, and very important and very involved in all of our conversations.
It's interesting. Border town, you mentioned it. I'm gonna come back to a word Brandy used earlier, and that's trust. Barbara McEnany shared this story. You know, she did come home. She's one of the founders of reform in her area. Good gracious, one of the pioneers to make this happen. But she shared a story that was really pulled at your heart, where they were trying to be good stewards and promote good cancer care. However, they were going to do some breast cancer screening, and they had a mobile van set up, and they were going to go to a remote area and do free breast cancer screening for patients. They didn't get much traffic. Finally, they saw someone sitting outside, and it says, "What's going on? While people are," and what was happening is the person that was around hanging out says, "Don't go in there. You're going to get cancer." So the emphasis of trust and getting to know the community, like, I'm really here to help you, be there for you. I want to be one of you the best I can and provide your needs where you are. That's got to be fundamental to get where you need to be, because the cultures are different. They think differently. They use different words, whatever. They see things differently. You got to get that foundation of trust first, and then hope, fingers crossed, things will work out for the good if you do.
Thank you, both of you, for those tips. The other thing we've seen practices do is look at patient populations where they do have supplemental coverage that will cover that copay. So patients don't have to pay out of pocket. Obviously, this varies a lot depending on the patient population and what they have access to. So, but that's another way to start, where there may not be a copay to burden those initial patients that you enroll in those services. As well as, I think, in financial counseling, looking at that overall picture through treatment with these as part of that can help, because when you see it in the overall picture of what the cost of treatment is versus the cost of those services, that may kind of even out over the time that they're in the program.
I have a question for Brandy, if it's okay.
Yeah, sure.
The CPT codes are real complicated, and time is emphasized in there. How are you guys keeping up with compliance on the time piece? That seems to be a question that many people have out there. How did you do that?
We are implementing it with our documentation. So when the care manager is reviewing the chart, he documents the time of when he starts, and he goes through and reviews the treatment regimen and reviewing the medications and everything before, and even looking at the platforms that we use to support our processes. So from the start time and then having the conversation with the patient, it all comes down to how you're tracking your time and documenting it. There are services out there that can do, and then of course you can review the chart. Have you had anyone on your team sending in prescription refills? And those things can also go into the time. We're primarily focusing on what we are doing as the care manager, and that's where we're gauging our time from. You can use other support tools to go in and audit the chart and add time. Maybe if you spent 5 minutes refilling a prescription, or you had documentation where a patient called in, or those can be supported. But for us, we chose that. Just, it was easier, more streamlined for us to focus on the time that we are providing to that patient. But there's several options out there for practices. But that was a great question.
Thank you.
Excellent. Well, I know we're close to time. I'll leave you with one last question and we'll close. So for each of you, what's like one tip you would give? Like, what should I get started with now if I'm a practice and I'm thinking either about quality and the certification, or starting with these care management programs to assist in my reimbursement? Bo, I'll just start with you.
Thank you. My email address, if you don't have it, I'll get it to you. Send you the standards manual. It's all out there. It is a start. It's just a blueprint to help you get started in your transformation, so that you can, like, hey, we're doing a great job. Do it, because that's going to be, the program will evolve too as we get smarter. We'll continue to evolve it. But the care coordination codes are mentioned in there, pathways, all the things, satisfaction, e-pros, all the things we're doing today are in there. It gives you a path forward to do so. Get started. You can do the certification later, but if you're not working on some of these things, go ahead, get it done.
And Brandy, what's your tip for getting started? Where would you go?
I would say just start having the conversations with your practice and your team, and what fits your size. It's not a one size fits all operation. For us, we chose to even just getting started, even if you're starting with 2 providers and you're reviewing the Medicare requirements, and you just want to keep it just a basic, simple process just to get your documentation in line, and reach out to your EMR vendors, because so many of these things can be built in or have already been done. So don't reinvent the wheel. If another practice utilizes the same EMR platform, for us, that was the case. So a lot of things were built into our EMR. The reports capabilities are there. And then again, just the partnering with great teams like Cardinal, or anyone that can understand the oncology landscape, and that you're having conversations with them to move the dial forward. So you're not just sitting there reviewing and analyzing, because we can just talk to and analyze it for extended periods of time without moving the dial to do anything about it. So it's important just to get started.
Thank you both, Brandy, Bo. Appreciate our panelists today. It was wonderful talking with you, and I hope our audience learned a lot about quality care and also getting reimbursed for that care.
Thanks for having us.
Thank you for joining a win-win approach, elevating care quality while maximizing reimbursement. We'd like to thank our sponsor, Cardinal Health, for supporting this important topic. To learn more about technology solutions that can help elevate care quality and ensure you maximize reimbursement, you can learn more about Cardinal Health's Navista Performance Insights by visiting cardinalhealth.com/performance insights. We look forward to having you join us for future webinars.